I am an interdisciplinary in full disclosure, so I truly believe that it's always best to start with looking at a whole patient, the biopsychosocial aspects, and treating the biopsychosocial aspects of disease. Neuropathic pain, of course, usually implies that there's a specific physiological lesion that, of course, people jump in and say, well, we'll target that with a drug. And that's, of course, appropriate, and there's been a lot of good and not so good research that's been done trying to identify specific drugs that treat specific conditions like this. But the interdisciplinary approach, I think if not adds a lot to the pharmacologic approach, it is superior in most contexts. And this again looks at the biopsychosocial aspects of disease, meaning if somebody's depressed or anxious or can't sleep because of the pain, then you can help them with things like cognitive behavioral psychotherapy and biofeedback and relaxation and sleep hygiene techniques, etc. If somebody has lost function, in other words, they can no longer work or they can no longer do things that are of value to them, then you can teach them how to work around the pain or work through the pain or work with the pain in regards to not only getting back to work, but getting back to fishing and getting back to spending time with their families. These are things that enrich life. These are outcomes that are undeniably critical for effective treatment of pain patients. Getting them to lower the number on a 0 to 10 score probably has some inherent importance, but to improve the quality of life, that nebulous term, but to do that directly and effectively is the whole ball of wax as far as I'm concerned. So if you are going to care for pain, you need to establish a relationship with a good cognitive behavioral psychologist, a good physical therapist, a good occupational therapist, social workers. You need to have these people on your Rolodex. You need to have these people on your Rolodex and or in your phone so that you can punch cognitive behavioral psychotherapy and you've got 2 or 3 people that you've worked with before. And then there's always that one that did the best job, was willing to call you and talk to you about patients when there were problems. The harried, overworked family practice doctor sends a patient finally to a cognitive behavioral psychotherapist. The cognitive behavioral psychotherapist calls and said, look, you really need to pay attention to this morbid depression problem that the patient has going on. Doctor can do that easily with a prescription in conjunction with the psychotherapist, and things completely transform. I can't tell you empirically in my life with tens of thousands of patients, because I was a teacher and had residents, how treating the depression or the anxiety or the sleep disorder or helping people to get back to work or rewarding life through the instrumentation of interdisciplinary care was much more important than moving a point down on the visual analog scale. The diagnosis of fibromyalgia has become extremely confusing and inconclusive. It's really difficult to read the literature, even for somebody like me who wrote some of that literature, and walk away with a clear idea of how to diagnose the disease. But if the clinician can just remember, it's a patient that comes in that is just incredibly painful all over, or as we call it, widespread pain. Just literally everything hurts. But also, and this is what the books and the literature will not tell you, they also all have great difficulty sleeping. They don't get refreshing sleep. Sometimes they just don't sleep. And they also have depression and anxiety in very, almost uniform, 95 percentile. You have to treat all of that. You have to appreciate, diagnose, and treat all of those three aspects: the pain, the mood disorder, and the sleep disorder, to have success in treating fibromyalgia. So that's my nugget about how to diagnose it. You're looking for these people that come in that are dysfunctional, they're upset, they're depressed and unhappy and exhausted and hurt all over. And that's how you treat it, is you treat all of those things. Again, if you take that interdisciplinary approach or a multi-pronged approach with patients, you'll have great success. If you do not, you will fail. Well, first of all, it's complex regional pain syndrome. Now, that was meant to be a general name that was a big umbrella so we could capture all these people and didn't do better research and break out the subsets. Well, we created the umbrella, but we never did the research and we never knocked out the subset. So we're still dealing with a very heterogeneous disease, which makes it very difficult to treat. It's easy enough to pick up the diagnostic criteria that we have validated and sit there and apply it to a patient, because it's just signs and symptoms, and you just check these off. If you have enough signs, you have enough symptoms, you make the diagnosis. So now what you've got is a heterogeneous disease. Some people are going to respond to drug A, and some people are going to respond to physical therapy, and some people are going to respond to cognitive behavioral therapy best. We've not done a great job of breaking out these subsets, and we've never done the job of proving that subsets of CRPS respond to specific interventions. So it's a mess. I would suggest to the family practice doctor, if you diagnose complex regional pain syndrome, you punt. I mean, I rarely say that. I don't tell my family practice doctors to do that flippantly, but it is such a complex disease with so many different sub-manifestations that it really is important to bring these people to a highly trained, functional team for treatment. I'm putting together a symposium, that's the singular, a symposium on ketamine use in CRPS in October. And of course, the reason I'm willing to do this, because I've never prescribed ketamine for a CRPS patient, is because there's a lot of people that are starting to use it. Opioids this week, I think, are bad. I don't know if, I forget exactly where the pendulum has swung, this week. They're good, they're the answer to everything. Now they're bad, and all doctors who prescribe them should be drawn and quartered and drugged naked down, Michigan Avenue. I can't figure. Where are we now? Opioids bad? Okay, opioids bad. Well, when opioids are bad, and that's the only thing that has worked for people like family practice, who are so busy that all they have time to do is write scripts, they're looking for other things. So thus, ketamine infusion centers are really taken off. And as this freestanding entity, you'll see these infusion centers popping up all over your city, wherever it is. I saw one pop up the other day in my city, even a little city like Athens. That's a scary thing to me as a researcher, because we don't have randomized control trials of the drug. We don't even have good empirical evidence that it works. We have absolutely no guidance as to what dose, in what diagnosis, and when and why, and all of that. So, thus, we're putting on a symposium about this to try to bring all this together, and importantly, what dose should we be using? Now, your question really is, does it work? And I should say that, like anything that you might try, shaking a dead chicken over somebody's head, probably 20% or so of patients are going to get reasonable relief from that. The same with ketamine. Now, ketamine is a potent drug, and it has a very interesting effect in the pain transmission pathway. So, I'm a researcher. I just want the evidence. I want the proof before I'm going to prescribe it. However, since it's happening and it's being prescribed regularly out there in the world, let's sit down and start talking about it. If we can develop a protocol that everybody agrees to use for their research, then we've made a big stride towards actually proving or disproving that it works. There's no company out there that stands to make a lot of money from ketamine. It's generic, it's cheap, it's used in every anesthesia center and clinic in the world. So it's easy enough to get the drug. It should be difficult to determine a safe and effective protocol for infusing it, but there is no such thing. So a lot of work to be done. It should be a great place to be if you're a young researcher and want to jump in here and try to generate some useful information. I believe that it will prove to be effective for subsets of CRPS.